Burosumab therapy in children with X-linked hypophosphatemia. Definition: X-chromosome-linked hypophosphatemia is a disorder of renal phosphate loss, and the most common injury form of RIG is caused by loss-of-function mutation in the gene that encodes homologous X-linked endopeptide regulation phosphate, which results in excess of circulating fibroblast growth factor 23. FGF23 is the primary regulator of phosphate homeostasis and acts by controlling the reabsorption of phosphate in the kidney.
X-linked dominant, it will not skip a generation. And there are few conditions in orthopedics for this problem. One of them is hypophosphatemic rickets or vitamin D resistant ricket. The other one is Lereuil dyschondroichthyosis. The hypophosphatemic rickets is important. I have not seen an exam that doesn't have hypophosphatemic rickets. It is a vitamin D resistant rickets. It's an X-linked hypophosphatemic rickets with inability of the renal tubules to absorb phosphate. Phosphate is down, linked to the PHEX gene, fix gene found on the X chromosome. It is the most common causes of rickets in the United States of America. If it comes in the exam, look at the three things. The child is short and the lower limbs got bowing or deformity, and the phosphate is low. There will be low serum phosphate. So because the body is trying to compensate for the rickets, so the alkaline phosphatase will be high. The calcium is normal, and the PTH will be normal. The parathyroid hormone will be normal because the calcium is normal. So the treatment, usually high doses of phosphate replacement and the high doses of vitamin D to facilitate the phosphate absorption. The other one is Lereuil dyschondroichthyosis, a rare genetic disorder caused by mutation in the SHOX gene, the short stature homobox containing gene, cause short status and bilateral Madelung deformity of the forearm. So if the mother is affected and the father is not affected, then the condition will affect 50% of the children, and it will be equal among the boys and the girls. So it will affect the boys and the girls. So if the mother is affected, 50% of the children will get the disease, and it will be equal between the children, male and females. But if the father has the disease, none of the boys will get the disease, but all the girls will get the disease. Again, it will affect about 50% of the children, but all the affected children will be the girls. The affected individual have an affected parents because it is a dominant gene. All affected males must have affected mother. All affected fathers have affected daughters and no affected sons. Look at the males, look at the sons, and look at the father. I hope you liked that video. If you like the video, please push the button like.
Application in nursing. Conventional therapy for X-linked hypophosphatemia consists of multiple daily doses of oral phosphate, salts and vitamin D, metabolized orderly as replacement therapy. This treatment transiently increases serum phosphorus level. However, it is associated with incomplete healing of rickets, residual skeletal deformity, persistent short stature, gastrointestinal side effects.
Hypophosphatemic rickets is a disease that always interested me. I started my training in '81, so it's now 30 years. It is not uncommon. We have about 20-25 children with this disease here at Children's Mercy Hospital between endocrinology and us, and there is excellent collaboration between the two sections. And the treatment, I would say, for the past 40 years was quite standard, providing very large quantities of phosphate and vitamin D. And this treatment, if it starts at an early age, is quite effective. The problem is that many of the patients develop side effects to these two medications. So that's the main problem. So it's a very delicate balance, giving the optimal dose of the medicine on one hand to achieve the therapeutic goals of correcting the rickets on one hand, while on the other making sure that the patients do not develop the side effects, the complications. And keep in mind, these side effects are being caused by us, the physicians. We are those who prescribe the medications. These side effects do not appear in untreated patients. And these side effects the two more common ones are either development of calcifications in the kidney, and you can see it very clearly on ultrasound, or development of complication of the parathyroid glands, hyperparathyroidism. My goal over the year was first to convince the scientific and community and also physicians that especially the complication in the parathyroid glands is due to the treatment. It took me a long time, I would say 20 years, to go to conference after conference and show my research results time and again until it became accepted. Now it's in the textbook. 6-7 years ago, a new medication appeared in the market. Again, this medication is designed or was made again for patients, mostly adults, with chronic renal failure to protect them from the complication of secondary hyperparathyroidism. But the mechanism is the same also in patients with hypophosphatemic rickets. About 3 years ago, we published the first paper, which is now very well recognized. And this was a short-term study in which we tested the kids only for 2 days and definitely demonstrated that the medicine has great potential in treating these patients. And since then, we have proceeded with long-term study, and the results are very encouraging.
Pros: Burosumab is a recombinant human monoclonal antibody that targets FGF23 in adults with hypophosphatemia linked to the X chromosome. Treatment with Burosumab, administered at doses of up to 1 mg per kilogram of body weight every 4 weeks, improve renal reabsorption of tubular phosphate, thus increase serum phosphorus to normal serum levels and increase in serum dehydroxyvitamin D levels. Cons: The treatment of daily doses of oral phosphate, salts, and vitamin D metabolic is associated with incomplete healing of residual skeletal deformity, persistent short stature, gastrointestinal side effects, and the risks of metabolic and endocrine abnormalities such as hypercalciuria, nephrocalcinosis, and hyperparathyroidism.
What is X-linked hypophosphatemia, or XLH? Well, it all starts with phosphate. Every living thing needs phosphate. Phosphate comes from many of the foods we eat. It's in our cells and bloodstream, helping the cells function properly. And it's also important for our body to produce energy. The majority of the phosphate in the human body is found in our bones and teeth. In fact, phosphate is just as important as calcium in making our bones strong. If you think of a sandcastle, phosphate in our bodies is like the water used to wet the sand. It helps the sand stay together, providing strength and support so the walls don't fall down. Just like the sandcastle needs water, your bones need phosphate to stay strong. A hormone in your body called FGF23 controls how much phosphate your body absorbs depending on how much it needs. Phosphate is either reabsorbed by your body or flows out with your liquid waste. For XLH patients, not being able to keep enough phosphate in the body is like having a leaky bucket. Instead of the water going where it needs to go, it leaks out and the sand doesn't have enough water to function properly. People with XLH end up with low phosphate levels, and without enough phosphate, their bones will be weak and soft, causing many issues. In children with XLH, their leg bones bow or bend under just the weight of their own body, and bones that should be straight will have a bend for the rest of their lives. Without enough phosphate, growth plates are affected and children cannot grow to their full potential. Since phosphate is also important for healthy teeth, people with XLH are vulnerable to tooth infections and can lose their permanent teeth as young adults. XLH is lifelong, and as people with XLH get older, their soft bones become more brittle. That means fractures can happen from normal everyday activities. Ligaments and tendons that connect their muscles and bones, typically at the joints, can become very stiff and sore, not wanting to bend like they should. Because the joint in the hip may be misaligned since childhood, they can feel worse as adults. Pain in the joints, muscles, and bones, and weak and tired muscles can make it difficult to do normal physical activities such as walking. XLH is an X-linked dominant disorder, which means that fathers pass it to their daughters and mothers have a 50% chance of passing it to their sons or daughters. However, approximately 20 to 30% of XLH cases are not passed down by parents. Understanding how important phosphate is to the human body and how the levels of phosphate are regulated will help scientists develop new ways to manage XLH. If you or your family members have some of these signs or symptoms, ask your doctor about XLH.
Issues apply in Ecuador. A total of 79 children were evaluated, of which 66% were eligible randomly, assigned to receive Burosumab every 2 weeks or every 4 weeks, 26 patients in each group. The 52 patients completed 64 weeks of treatment were included in the efficacy and safety analysis and continued in the extension period.
Hypophosphatemia is associated with increased risk of mortality in ICU patients. Phosphorus is important for human body, for normal neurological functioning, and muscle contraction. Hypophosphatemia is a common electrolyte metabolic disturbance reported in critically ill patients. Several studies have shown that hypophosphatemia is associated with increased risk of muscle dysfunction and arrhythmia, and longer hospital and ICU stay. The aim of the study was to determine the association of hypophosphatemia and the risk of 28-day mortality in ICU patients. The study involved reviewing data of patients who were aged 18 years or above, whose serum phosphate level were measured at the time of admission in the ICU, and survived up to 28 days after admission. Patients who were pregnant, or stayed in hospital for more than 180 days, or had serum phosphate level more than 1.60 millimoles per liter, were excluded from the study. The retrospective, single-center study included 946 patients. Based on the serum phosphate level at the time of admission, subjects were divided into 2 groups. Normal phosphate group included 442 patients, and hypophosphatemia group included 504 patients. the ICU 28-day mortality and its association with phosphate level was evaluated. The risk of ICU 28-day mortality was higher in patients with hypophosphatemia as compared to the patients with normal phosphate levels. The study results concluded that hypophosphatemia at the time of admission in general ICU patients is an independent risk factor for 28-day mortality.
Conclusion: in children with X-linked hypophosphatemia, treatment with Burosumab improved renal tubular phosphate reabsorption, serum phosphorus level, linear growth and physical function, and reduced pain and the severity of rickets. Burosumab have beneficial effects on serum phosphorus.
X-linked hypophosphatemia is an inherited disorder of renal phosphate wasting that leads to rickets, osteomalacia, stunted growth, and ultimately lower limb deformities, pain, and physical disability. It's caused by a genetic mutation leading to excess production of fibroblast growth factor 23, which impairs renal phosphate reabsorption and vitamin D synthesis. An open-label Phase 2 study evaluated the efficacy and safety of Burosumab, a recombinant human monoclonal antibody against FGF23, in children with X-linked hypophosphatemia. 52 children 5 to 12 years old with X-linked hypophosphatemia and active rickets were randomized to receive subcutaneous Burosumab every 2 or every 4 weeks, titrated to achieve low normal serum phosphorus levels. Follow-up measures were assessed after 40 and 64 weeks. By week 40, the mean radiographic Thatcher-Ricketts severity score decreased from a baseline of 1.9 to 0.8 with every 2-week dosing, and from a baseline of 1.7 to 1.1 with every 4-week dosing, and the improvements persisted at week 64. Mean serum phosphorus levels increased after the first dose of Burosumab. Over half of the patients attained normal levels by week 6, and the every 2-week dosing maintained stable levels through week 64. The mean standing height Z-score increased overall, patient-reported pain was reduced, and physical ability improved. Most adverse events were mild to moderate in severity. The authors conclude that for children with X-linked hypophosphatemia, Burosumab improved renal phosphate reabsorption and serum phosphorus levels, reduced rickets severity and pain, and improved growth and physical function. Full study results are available at nejm.org.